Let's talk about B-cell maturation antigen. BCMA is a cell surface protein that is expressed on multiple myeloma cells. BCMA is essential for the proliferation and survival of multiple myeloma cells. BCMA is a target under investigation because BCMA is present in 100% of multiple myeloma patients. Just goes to show, some facts are more meaningful.
CC-93269 is an IgG1 based 2+1 T-cell engager. It has a bivalent binding to BCMA with high affinity and a monovalent binder to CD3 with low affinity. That way it can bridge T-cells with BCMA containing multiple myeloma cells. It also has an Fc portion that has been modified and prevents binding to Fc gamma receptor, and to complement, therefore minimizing the risk of infusion reactions. This drug was shown to have a very significant anti-myeloma activity in preclinical models, triggering this phase 1 first-in-human trial. So this phase 1 enrolled a heavily pretreated patient population. About a third of the patients had extramedullary disease, a third had high-risk cytogenetics. 80% were refractory to a PI, 80% refractory to an EMID, 80% were refractory to a CD38 monoclonal antibody, and 2/3 of the patients were refractory to all 3 classes of agents. This was a dose escalation, dose finding study. Patients received the agent once a week for the first 3 months, then every other week for another 3 cycles, and then once a month. So the study is ongoing. We have not yet reached a recommended phase 2 dose, but we have clearly reached an active dose that induces response in our experience in most patients. The most common and most important side effect profile was cytokine release syndrome. That was seen about 3/4 of the patients, but with very few exceptions, those cytokine release syndromes tend to be grade 1 and grade 2, and they tend to happen with the first infusion, become far less common with the second and subsequent infusions. So we enrolled 30 patients in this study. The overall response rate across the study was 43%, including 17% of patients who reached a complete remission. It's important to note that response evidently was dose dependent. We had no patient responding at the dose of up to 3 milligrams. At the dose of 6 milligrams, we had 36% response, but at the target dose of 10 milligrams, 89% of the patients responded, including 44% of patients with complete response. Very important to notice as well, the response tend to happen rather quickly, and all the complete responses were also MRD negative, oftentimes already at the end of the first cycle.